Welcome everyone to today's panel discussion. I am Robert Kurtz, facilitator for the program. Today's panel discussion is brought to you by Proem, developer of the evidence-based clinical workflow software engine that helps providers triage patients and produce better mental health outcomes. We are recording today's program, so all attendee lines are muted. Attendees will receive an email that provides a link to the recording of today's program. Our panel discussion will begin with our moderator and panelists introducing themselves to you. They'll then discuss a series of top issues concerning behavioral health and answer your questions. You can submit any questions you have throughout the discussion via the Q&A button on the bottom of your screen. We have a large audience with us today, so our panelists will not get to all of your questions, but do not worry, they will work to follow up on those questions they do not have the opportunity to address. And with that, I'll now turn the floor over to Dr. Tom Young of Proem to lead us into today's program. Doctor?
Thank you, Robert. Good afternoon, ladies and gentlemen. Pleasure to have you with us. I'm honored to be able to bring you this panel of experts and bring you some good information, hopefully, about behavioral health in 2023 and where we all think it's going and how we think it's going there. So I'm going to start by asking each one of them, and I'll start with David, to introduce himself, and then we'll go around the panel and we'll go from there.
Thanks, Dr. Young. My name is David Purrington. I'm a managing director with Vertes Healthcare Advisors.
Thank you, David. Josh.
Greetings. I'm Dr. Josh Spitownik. I'm a licensed psychologist, board certified in behavioral and cognitive psychology, and I'm the founder and owner of Anxiety Specialists of Atlanta, an outpatient specialty center specializing in treating anxiety and OCD.
Thank you, Josh. Troy.
Hi, I'm Troy DiLello. I'm a consulting IT executive in the behavioral healthcare space.
Thank you all. So let me kick this off by just asking a simple question. What one word would you each use to describe what transpired in behavioral health in 2022? Let's just looking back for a moment. What's that one word that comes to mind?
That's
David?
not a simple question. Accessibility.
Accessibility. Thank you.
I have shortage.
Shortage.
I'd go with utilization.
Okay, utilization, accessibility, and shortage. Okay, so asking sort of down that same line, we had some things change. The U.S. Public Health Service Task Force added some new recommendations for screening, particularly for anxiety in children. How does that affect those three issues? Number one, from last year and going forward this year, what does that do? How does that affect what we're going to be doing in 23? So I'll focus this, and some of it was to anxiety. I'll ask Josh first. Josh, how do you think the anxiety piece for children is going to affect 2023?
Well, first of all, David, myself, and Troy did not plan for those three words, and thank you for setting us up for that. But those three words actually so well complement each other and conflict with each other. So as an anxiety specialist, as a psychologist, as someone who's in the field providing services in the Southeast United States, but also in 30 other states, as my team does, that task force has kind of requested, if not almost mandated, that primary care serve as the leading group, boots on the ground, to start screening for mental health issues and specifically anxiety time, Tom, which for me is wonderful because it increases the potential accessibility of kids getting their needs met, at least as an initial screener. And then we get to, which is my word, and then Troy's challenge is behind accessibility is utilization. No, I'm sorry, his was, Troy?
Shortage.
So you have so many primary care providers increasing awareness to parents and families about the needs of mental health and some basic screeners for anxiety. And now we have the real dilemma, which is how are we going to get these kids who do get flagged for their needs access to good mental health care? And that's where the shortage kicks in. And so to then David's point of utilization, we've got to find a way to utilize practitioners out in the field like myself, who are not wonderfully integrated with primary care, being accessible to the field. So that task force is critical because it puts mental health on the radar more so than it has been in years previous. And that's a great start. But how do we get primary care to integrate with and connect with behavioral providers like myself, from screening to actually access to care? That's a real challenge.
Thanks, Josh. Well, I think, yes, the challenge of integrating behavioral health into primary care is going to be an ongoing concern in 2023, and it does affect the other things. How does it affect, for example, the payer's view? What do we see happening in the commercial and federal spaces and payers and their approach to behavioral health in 2023? How does that seem, Troy? What are your thoughts about that particular space, the payer space, commercial and federal?
What a huge question, because we're not seeing a lot of changes in 2023 in that space. And when we're talking about integrating primary care with psychiatry and psychology or mental health, there's no codes to support reimbursement for that. There are, but they're minuscule amounts of reimbursement. And that, as long as that continues, I think we have this obstacle, and we need to figure out how to get over it. And how is that time paid for? How do we plan for that? What about reviewing records? What about storing those records? How do we get those records? Because if you're in an HMO, a group or something like that, or a FQHC where you do primary and you do behavioral health care, there's an advantage there because you have maybe one EMR. But for a lot of us, we're an outpatient, and how are we going to get those records? Who's going to send them? Who's going to fill out the request of information? Who's going to receive it? It's a lot of work, and that's something we really have to figure out.
Okay, David, where do you sit in that conversation around payers, both commercial and federal, as we move forward in 23?
Yeah, well, for one, Troy, I'd certainly echo that sentiment there. I actually lost a deal in 2022 because the charts were initiated at an inpatient hospital, and so the outpatient provider, for whatever reason, the buyer sort of got into this challenging argument of, well, who actually owns these charts, right? And because the outpatient provider is adding to them and has their own EMR as well, there's just a challenge there. And so I think that integration of EMRs, EHRs is probably going to be a big deal. And it's like we plan these ROIs on intake, and then what happens after that, and how much better positioned would the primary care physician be if they have all that information. So I love that vein of thought. I would probably approach it from a different angle, though. My angle would be more, I'd start really with the shareholders of the payers, who are looking at this destigmatization of behavioral health, which has occurred for well over a decade, but really since the pandemic, it's been a tidal wave. And so, these are expensive benefits to pay for. And so they're kind of, I think, looking at the shareholders, at least, who in the public markets are looking at a 6-month time horizon, are saying, how am I going to get my APS up? It's a simple game of addition and subtraction, money in, money out. And so though they know over the long haul that investing in population's behavioral health will reduce the total healthcare spend on a patient's lifetime, the public markets are a 6-month time frame. So I'm leaving CMS out of this for a second, really kind of focusing on the commercial ones. And I think that's where some of the challenges, and I think that's also where we're sort of seeing some of these payers posture, particularly in 2022, some of the posturing that's gone on. And I definitely see that proliferating more in 2023, especially with the movement of value-based care.
Well, and that brings up sort of a follow-on question that I would ask is, do we expect any changes in reimbursement in 23? Are we looking at opportunities for change in reimbursement?
Well, I have some bad news on that topic. We've already seen
Me
one
too.
we've seen one significant one. So in my field, which is behavioral mental health in general, but anxiety specifically, we'll get to this in a few minutes, I know, when we talk about values-based care, hopefully today, but in the evidence-based space, which Proem is a leader in, evidence-based healthcare and anxiety is undeniably proven. There's some wonderful interventions out there, non-pharmacological interventions in behavioral healthcare for anxiety work, primarily things like exposure therapy, cognitive behavioral therapy, acceptance and commitment therapy, a lot of mindfulness-based CBT, really targeted symptom focused, teach the person how to be their own therapist, get them out of therapy, and help them maintain their gains on their own. Something that my team loves to do, something I like to train people on. And in some of those interventions, we do work beyond the typical 90834 hour. And I think January 1, 2023, I found out that they have eliminated, at least for now, what's considered sort of an extender code, which is that if you want to provide services as a behavioral health care provider beyond that typical 90837, sort of that and kind of that 55 to 70 minute window, which some people think, why would you be in therapy for more than 45 minutes? Some of the interventions out there for trauma, obsessive compulsive disorder, anything under the space of exposure therapy being one of the leading proven interventions for anxiety disorders, requires at times extended sessions. We do work outside of, this is my therapy office. I do work outside of my office almost as much as I do in the office, whether I'm doing video or in-person therapy. And insurance has now eliminated that extender code, which means they are not wanting to pay for what's demonstrated to be the most effective methods to treat anxiety disorders, and doing so in the most short and the most efficient time. So just to kick off the new year, a lot of us were punched in the face with not being able to seek reimbursement for extended sessions, which are required for some of the work that we do.
So the challenge of reimbursement is suddenly there's lack of it.
It's
And
another shortage, right?
Yep, another shortage.
And it's right on my radar too. 908, was it 53 or something? I can't. Oh, I'm sorry, 99354. Right? That was the
99354.
extent. That was the code for extended services. And I had a therapist call me the other day and said, "Hey, how do I code this? I spent 2 hours with my patient. They were in crisis." You get paid for an hour. That was the answer. In 2023, the payers have decided that you can't do that. And so, what is that saying to us? As business owners, as clinicians, I think it's the wrong message. And I just, I hope, I know they're working on some of that. I think there's some in-facility codes that they've come out with and that sort of thing. But I've been scouring since, the new year for how are we going to deal with this? Because it's not fair. It's another shortage.
okay, so the reimbursement piece falls into the first three things you gentlemen said in each and every way, in the sense that they impede, increase, or make worse each of those three words. So that's not a good look for 2023 in terms of all of us in the space. Well, if we sort of move beyond that, and I think Josh, you alluded to this, and we move to the conceptual framework of value-based care, do we see, what are your thoughts on behavioral health making the move into value-based care? That becoming more the forefront of 2023. How would you look at that?
So I would start just by saying value-based care, in my view, does a lot of really great things for our industry. It professionalizes it in some pretty substantial ways. It also means lower industry revenue. But there's winners on value-based care. And so it really comes down to, I think it was you, Josh, that brought up documentation, or maybe I think Troy, you brought that up, but just that's a big part of value-based care, is being able to, prove that you are meeting these minimum requirements of compliance for whatever your state requirements are. So I think it's important to sort of couch it in this lens of like, it probably does mean lower industry revenue overall. That doesn't necessarily mean that any particular provider is going to experience lower revenues though. And so it's being positioned well for this movement. And some of the things that we were seeing in due diligence in some of the deals that we were working on last year, almost kind of paint this picture that even if your agency is not piloting value-based care contracts right now, that some of the principles in value-based care are going to start being applied. So case in point, we noticed one of the buyers for one of our deals this last year decide not to actually perform a quality of earnings, which in an M&A process is usually one of the cornerstones of due diligence. Instead, they opted to do a compliance and regulatory audit. This is not a provider that was engaged in value-based care. And so it just really struck us as interesting that these buyers who focus quite a lot on what's going to happen over the next 5 years in this space put so much emphasis on compliance and regulatory.
An important point. Josh, your thoughts?
So the value-based care space is interesting for me. Again, I take it for granted that the team that I work on and most of the providers that I connect with around the country, organizations I'm a part of, that it's built into our work that, to me, evidence-based care is values-based care and values-based care is evidence-based care. It's following the science of psychiatry and behavioral health, looking for the most effective, efficient, cost-efficient, clinically efficient ways to get someone to the end point where they can really take care of themselves without a provider. I love that. It's what I talk about. It's what I train on. It's what we offer here. But Tom, to be blunt, I don't know if the field itself is prepared for that. I think in medicine, it's a no-brainer that most of us would not go to a provider that doesn't follow the science, whether it's about robotics, pharmacology, surgery, colonoscopies. I couldn't think of a physician, and you know, that, and I'm even speaking to sort of even the holistic groups where science is not embedded into the training and work they do. And I'm embarrassed to say this as a behavioral, scientist, but in my field of psychotherapy and behavioral health, it's the Wild West of training. And I think for us to even conceive of reimbursement or companies considering putting finances behind evidence-based, values-based practices, we need to see a significant increase in providers in my field, behavioral specialists, being able to actually deliver values-based care. And I think if you surveyed therapists, psychotherapists, which have all sorts of credentials around the country, I'd be shocked if more than 25% are practicing from a manual. And even though I have lots of manuals back there, I'm using flexibility within the fidelity of the manual, but there's still science rooted in the work that we do. And I'd be shocked if more than 25 to 30% of my field is citing, working, training from, and delivering manually based interventions. So as much as I'd love to see payers and insurance panels really consider the work that we do as an integral part of adapting and adopting to their pay structures, if I'm them, I'm expecting my field to step up and be much more driven by the science to offer more efficient therapy, more effective therapy, and therapy that gets someone off of their co-pays as soon as possible. So I love it. It's what we do. And I also know insurance doesn't like to pay for it yet. So it's a double-edged sword, I believe.
One thing I'll note on that topic too, Josh, is on the addiction treatment side, I really do like the value-based care concept of some of the pilots that we're seeing, where it kind of puts the control back into the clinician's lap, where no longer in some of these pilots are the insurance companies dictating how long a client needs to stay in a particular level of care. It's now the clinicians that get to decide that. They get a chunk of money for a month and can make the decision if they should step that client down into a lower level of care or keep them at RTC or DTX levels of care for a longer period of time. I'd also say that I think the Optum acquisition of Refresh Mental Health back in March of last year is going to be a really important one for us to pay attention to this year. The stated reason for that acquisition was to explore value-based care in the outpatient mental health setting. So I think we're going to get a lot of really good information this year on what we should expect to see in these VBC movements, particularly in the mental health space.
Okay. Troy, any thoughts on the value-based care issue in terms of shortage?
In terms of shortage, it seems like all my answers are really negative. So I'm just going to say there's reporting requirements, and it takes some effort to do that. And so there's some cost and some thought that also has to go into the operational side of that to report it and to get paid properly and so forth. So it's an area of interest to me. It's not something that I am deeply involved with, but I'll be here watching it with you guys and welcoming it as it becomes more realistic in the behavioral space.
Well, legging off from that for just a minute, to kind of ask a sort of an aside question, how is technology and specifically virtual available therapies, do they play into improving the value-based picture? What do you think?
I'd love to hear Josh's reply on this, but I know there's VR now. There's so much, we have all these wearable devices. From my standpoint, having deep roots in technology, I'm really excited about it, but it's also, just because it's there doesn't mean it works. So.
Well, I can tell you from the telehealth space, there's actually been research just throughout the pandemic, some before the pandemic, before the need really escalated, but there's actually pretty good research that suggests there's not a lot of degradation in the quality of care, which is exciting and embarrassing actually for my field, across teletherapy. I mean, there's a lot of loss of intimacy of behavioral health in this platform that we're talking right now. But again, if you're doing good symptom focused and compassionate care, I think people have found creative ways to figure out how to do it without losing too much of that, that real intimate part of talk therapy. Troy, I like you mentioning a virtual reality. There's a lot of other wearable devices, sort of ecological momentary assessment devices that help us track symptoms in real time. But if I just step back and use the lowest hanging fruit of technology, Tom, which would be this platform, whatever, video platform you have embedded in your EMR, if you're using a third party, I think it's fantastic. I'm going to take this discussion to more of a positive place. I know there's a lot of questions about the quality of care, and a lot of .com companies have opened up to offer significant teletherapy options, and that really is, I don't think, with the best trained clinicians. It has made specialists like myself be able to practice across state lines without worrying about the legal ramifications. And for psychologists around the country, a governmental congressional project called PsyPACT, PSYPACT, has allowed clinicians like myself to be able to practice in over 32 states right now without having to beg, barter, barter and plead for states to, not slap me on the wrist for seeing someone who's in crisis or who just wants quality care. And now master's level clinicians, I know the professional community, the LPC counselor community is in a similar push to get interstate regulations to sort of decrease those requirements of having to get licensed in all these states. So I know there still requires a lot of quality of training and people learning the ethics behind technology and how to maneuver it and use it in positive ways. But I think the virtual space has, back to accessibility, has really allowed people who want to get really good care to not have to cross state lines or break rules to see a specialist. There's never enough specialists out there, and that'll always be a challenge in any discipline. But I love meeting someone from, Pennsylvania, New Mexico, Florida's not in it yet, even states next to me, the Carolinas and Alabamas that I could never legally see, who want to get, seen by someone I think are the best providers out there. I think it's offered sort of the Wild West, the boom, the gold rush of quality providers spreading what they do out there. And I think it's a great shift in the right direction. I do think there needs to be regulations about kind of the care that's being delivered and how we manage it, and knowing the ethics and utilization of technology, which a lot of clinicians are not up on. But I love that people around the country can find specialists and possibly connect with them across the country. I just think that's fantastic.
And I love that you brought up 2 points there. One, that the efficacy of virtual care is up. It looks pretty strong. I would even wager to sort of guess, at least, that if we were to ask you that question 3 years ago, you might have been scratching your head and saying, like, I don't know, or maybe even, no, I don't think it will be as efficacious as
I was betting on it not being, actually.
Right. And
Yeah.
now that we're years into this, it's like, wow, this really does work. And it should, right? We're not necessarily checking someone's pulse. We're engaged in talk therapy. So it makes sense. And we really extend that into integrated behavioral health, and a world of possibilities opens up. One thing I really want to point out, though, is I guess really sort of 2 things. One's a little bit on the downside, and one's really on the upside. So on the downside first, my concern, I think, with telehealth right now is just changing reimbursements in it. So we're seeing revenues really not in line with expenses. And so even in the M&A process, we're seeing some buyers recasting financials to essentially find a better margin that they feel more comfortable with. And so, not to say that there's any bubble in it by any means, there's a lot of buyer interest in that, like serious dollars are flowing into this area. And I think that's evidenced by, or the reason for that is because it works so well. But I do think that there's probably some turbulence coming in the years ahead in terms of reimbursements and what the revenues look like on it. On the other side, though, one of the things I'm really excited about is just all the data that we can get out of this, and seeing how care modalities may evolve over time. So take brain spotting, for example. The guy that figured that out, he was working with an ice skater who couldn't land a triple Lutz, and I'm genuinely not sure that that's what it's called. But she couldn't land a big spinning move. And he noticed that when she was going to land, her eyes were pointing in a particular direction. And somehow that proliferated this or created this new modality, brain spotting. I think with the trillions of data points that we're going to get from eye movements and voice fluctuations and even just the words being used, we can probably anticipate some new modalities of care coming up in the future years that I think is going to revolutionize behavioral health.
So what I hear you saying, just to sort of translate that for a minute, into sort of a different jargon, we're going to move from subjective assessments to objective assessments in behavioral health. We're going to be looking at much more data points as opposed to the subjective assessment of asking questions and getting answers. We're going to be looking at eye movement. We're going to be looking at facial recognition. We're going to be looking at other pieces of the HRV, other pieces of data to add to the robustness of our understanding of mental health and behavioral health disorders. Is that a safe statement?
I think so. And I think that's exciting. I think that pushes behavioral health forward in great strides. So.
Okay, I want to come back to something we talked about earlier, and that briefly, and that was how do we, because we're talking about primary care doctors, as we all understand, are sort of the bulwark of mental health in this country. How do we integrate? What's the process model, and how are we doing in this integration of behavioral health in all of its intricacies and nuances into the primary healthcare model, and separating that maybe from the family medicine general model to the pediatric general model? Where's that going in 2023 in people's minds?
I think there's some amount of work that needs to be done before that's easily accessible, and again, I'm going back to the administrative stuff because that's what I do. But these, we do see these EMRs starting to talk to each other a little bit. I know Epic will talk to Athena Health, and Athena Health will talk to maybe Cerner. I can't remember. There's still going to be some hurdles to get over with the smaller telehealth EMRs and so forth. But we are starting to see these companies kind of come together and realize, okay, we need to start talking. And I think that's a fundamental need that we're going to have, because behavioral health clinicians want records. And then the question, we talked about this earlier, but then what do we do with those records that are created on our side? So when we've seen the patient, we have our progress notes, and do we reshare those with primary care? Is that, some people do, some people say they shouldn't see it. And there's a whole bunch of decisions that need to be made and systems that aren't quite there yet. But I think that I see some progress in that area.
Yeah, I could see some. I'm sure it's already happening, Tom. I'm not in this space that much, but I could see some entrepreneur coming in to a major city and trying to become a parent company to 2 or 3 large primary care facilities and scooping up a large group of individual therapists or practices like ours. I'm a medium to large size practice, and trying to sort of create this umbrella group as a choice, using a technology umbrella to bridge everyone together. So even if you're not in the same brick and mortar, which no one's going to be, finding a way for all of us to sort of easily communicate, collaborate, integrate without a lot of legal and financial barriers. Do I want my progress notes shared to my primary care provider of the kids I'm seeing? I'm not sure, but I'd like the option to be that without me having to fax and download stuff and signing all these, release information. So I could see it, whether it's in 23 or not, I could see the next 5 years with this mandate of doing a lot more screening on the primary care side, finding groups that come in and say, let me help you guys synthesize your records and your collaborations. And it's going to require patients and consumers like us to agree that, sure, I'll let my primary care doctor and my psychiatrist or primary care doctor and my therapist communicate without a lot of the barriers and hoops that we currently require. I think that's exciting if that expedites access to care, if it expedites communication between professionals. I have a psychiatrist that'll call me literally on my private line, and I might not get back to them in a few days, or vice versa. And whether I'm proud to say that or not, that's unthinkable in care coverage. So the ability for us to almost communicate digitally in a very safe, HIPAA secure way that adds to the quality of care, I think is fantastic. But it's going to take a rogue entrepreneur to figure out how to do it in select cities and then make that more of a national thing The VA, I believe, is probably still the largest integrated healthcare system in the world. I think the United States Veterans Affairs System, by no means is it the most effective or efficient. It's a clunky system, but they
Pretty bad.
integrate it all. It's a disaster. I'm not on the tech side. I used to work with the VA. That's a disaster. And so I know I'm not going to.
use little.
I'm not
It's
going to name
terrible.
brand any big hospitals. Some that have been, had unions picketing in the last few months in California, but there are large hospital systems that have sort of brought that all together. And I could see it at a grassroots level, watching some sophisticated groups coming together using technology to bridge primary care groups and behavioral health groups together, and seeing if they can, at a local level, start bringing these groups together to increase communication and increase efficiency of care and communication. I mean, that's exciting, but it's going to take a lot of financial and technology savvy to pull that off.
I think there's some low-hanging fruit too. So, talking about big major hospital systems and the industries in general, I would agree. It's like 5 years. Who knows when we're going to actually see more integrated behavioral healthcare? But the lower-hanging fruit is probably more along the lines of just, for example, I'm seeing a lot of private capital being aimed towards the comorbidity between behavioral health and pain management. So there's a buyer that I'm working with that's constantly hounding me, trying to find them groups to match up like that. And so it'll be interesting to see if they're able to pull the trigger on some of these and some of the results that they're expecting on that.
So what do you think are the largest roadblocks that we're facing today in 2023 in that bringing it together? I heard what you all said. Are there specific things that could start to happen in 23 to lay the groundwork or provide at least the impetus for that integration between substance abuse, pain management, primary care, and behavioral health? Any thoughts as to if there's one or two things that should happen in 2023 that could get us there?
Well, I'll just start by saying I really appreciate that both Troy and Josh were scratching their heads a little bit on some of these answers, because I've been scratching my head on that as well. And you guys are deep into this. And so on the SGD, on the addiction treatment side, I think there's a very obvious thing that the ROI is sort of stage one. And I would agree that I'm not sure that it makes sense to sort of release all that information right to the PCP at intake, but starting to move the needle a little bit more in that, I think it's going to be a big boon for the SUD side.
Okay.
I'm going to adopt Josh's answer and just say I think we're going to need that rogue warrior, to jump in and say, I'm going to make this work. Here's my reasons, whatever they are, backed by capital or whatever it is, and start putting groups together. And I think, sorry, Josh, I'm just stealing all your stuff, but it needs to start. I think it does need to start kind of at the local level too. I agree. I had mentioned HMOs or FQHCs, that it's all in-house or close to in-house, where they're using the same EHR. If we could start somewhere, I think we need that for the inertia to go forward.
And I think, Tom, by the way, Troy, I appreciate you being kind and using some things I said. I think the real obstacle is getting someone like me to trust medical and getting medical to trust us. There is not accidental breakdown in communication and credentials and access to quality of care and what psychiatrists are allowed to do. I mean, even every time I write a camp letter for some kid and written by a physician, I'm like, well, I'm not a physician, but they really want me to write the letter, but I know they want a physician. So even the linguistics, the language, the semantics of what a doctor is, a medical doctor versus a non-medical doctor. I think getting some more collaboration between behavioral health care as a macro, which involves psychiatry and psychotherapist and medical. But really, I think if anyone came in and did something like this, it would require you to convince someone like me that it's not going to add more work to my plate. In fact, it's going to get my patients more quality care and reduce crises and acute needs. And then you'd have to convince primary care that it's going to reduce the number of people that they have to prescribe medications to, who still are the largest prescribers of medications above psychiatrists. So if you can find some way for this integrated model to reduce the prescriptions coming from physicians and pediatricians, which they'd love to reduce that burden, especially with the black box of SSRIs, and you can convince someone like me where you're actually not increasing the paperwork and chasing money, if someone can get through those hurdles on both sides, I think you have a workable solution there but it requires someone to really understand both the medical side, the behavioral health side, and where finances all come together. And it's doable. I mean, you have 4 people in the screen. It's doable, but it's going to require some out of the box thinking and some people willing to take that risk.
Okay. So we've talked about value-based care. We've talked a little bit about what we think is going to happen. Are there any other additional thoughts about how we're going to move more aggressively in 2023 to the value-based care model in behavioral health? Any other additional kind of comments about that movement? Okay, so let me ask this question. State laws. Josh, you alluded to it. Changes in state laws related to the ability to deliver care across state lines, changing for psychologists, changing to some extent for physicians, changing to some extent for nurses and nurse practitioners. Are there other state law areas that need to be addressed in 2023 to improve the landscape of behavioral health besides the cross-state barriers for licensing?
Can we talk about federal laws?
No, certainly federal and
Okay,
state
all right.
laws.
I think the one I'm deeply involved with is the Ryan-Haight Act, that essentially says that telehealth prescribers can't effectively prescribe medications unless they've seen the patient in person. It's a very archaic law. I don't think it's ever probably protected anybody. The DEA's involvement with that, and this is a huge obstacle to telehealth, to psychiatry in telehealth. And I'm very we're dealing with this every day. If we have prescribers who have ADHD patients and they're prescribing stimulants, the pharmacies are now denying the prescriptor. They won't fill the prescription based on that it might not be the right thing to do. There's a lot of just really gray area right now in prescribing, and like we've broken the barriers in telehealth for so many other things. I think it's time to break the barrier for prescribing too. There's not a real big difference in seeing somebody in person. We talked about this earlier, right? There's not a huge difference to seeing somebody in person and prescribing something, because you're not in a primary care setting. You're not taking their blood pressure, as opposed to prescribing it over telehealth. And I think that is that's a barrier that we need to push down.
Troy, I think you're spot on that. I've heard a number of buyers voice that same concern. And so just to sort of paraphrase again, the concern is that in 2018, the DEA was supposed to roll out a process for MAT providers to prescribe over telehealth. They still haven't done it. So we're still operating underneath the public health emergency that's allowing them to do it. And so I've heard buyers sort of equate this to investing in a drug before it gains FDA approval. I don't know if it's that extreme, but it's definitely on the radar for buyers. So I think you're spot on. I'd say another thing would just be, a lot of regulation is done at the state level. And so having some symmetry between all this at the federal level, I think would be a huge help. Dr. Young, back to your question though, some state laws that changed around in 2022, and could there be any effect on? Not to be nuanced for the sake of being nuanced, but there's a very nuanced state law that was repealed in Minnesota last year called Rule 22 or Rule 25, I think actually. And that was an assessment protocol. So you had to have a Rule 25 assessor in Minnesota determine what level of care a patient needed to be intaked into. That was repealed in July. And so I think, as it relates to your question, Dr. Young, my concern would be that, in a state like Minnesota that used to require these Rule 25 assessors, that admissions teams let's just be honest, they all have their metrics, right? They've got to get folks into the program. And so they may, and hopefully they don't, but they may end up circumventing some of the guidance around choosing the appropriate level of care to intake a person into in order to meet those metrics. So I think that would be a concern that I've got.
I'll throw one more on the fire. I don't know how many even providers even know about this. The Good Faith Estimate, No Surprises Act
Oh, yeah.
has literally
Mhm.
destroyed my field. So I don't want to dive deep into this, Tom, because it's not the point of this hour. But around December 22nd of 2021, the government ruined a lot of people's holidays because they made a bunch of behavioral health providers who don't know a darn thing about this terrify themselves. We are so ethical, which is a good thing. Psychologists, licensed professional counselors, marriage and family therapists are so darn ethical that we are terrified to break any laws. And I, in the last year, have been to so many physicians who have no idea what I'm even talking about, which is laughable, that this No Surprise Act Good Faith Estimate requires us to now put out in a digital document and in paper on our website, in our waiting rooms, if you have brick and mortar, which I do, and in their EMR or billable sections of however they, see their bills. Here's how much I'm going to charge you for the next year, which is a wonderful way to scare people off from getting their care met, because no one wants to see a pre-estimate bill from a therapist for, $1,600. So this is not a state thing, it's a federal thing. But around the holidays of 21, all these therapists like myself freaked out, and most medical people went on their lovely vacations. I'm sure I'm being a little bit of a jerk right now as I'm saying this. And in 2022, it hasn't been fully integrated, and there's still a lot of behavioral health people that are, putting these out there and appropriately trying to follow the laws, not even understanding what the laws shift every few months about what we're supposed to document. And if someone's not taking insurance, if they're not using their insurance, what if someone doesn't have a diagnosis yet? You're supposed to give them this before they've even had an intake. How am I supposed to give someone an estimate of services if I've never even met them? And I understand these were for MRIs and for ER visits and for hospital visits, but they were applied heavily. And, we were beaten over the head that behavioral health providers need to put these in place. I don't know who we need to talk to about that, but if we could remove that for therapists who are just trying to do a good job helping people, the thought about pre-documenting the cost of services when you don't even know if someone's even safe is the most insane thing I've ever heard of in my 25 years of being a healthcare provider. So it's not, again, a technology question. It's not about state by state stuff. It's the government appropriately trying to regulate, not scaring us patients into paying for something that we shouldn't at the hospital level, but a bunch of individual therapists around the country trying to figure out how to do this. And it's, I think, literally limiting consumers, clients, patients from continuing with care when they see these sticker shocking estimates that are not real, but we have no way to get around it. And boy, was that a fun thing to go through last holiday season.
So the unintended consequences of a law. It was designed
A limited care. You have people before they even meet with me go, I might be charged what? Never mind.
Yeah.
That's unthinkable. You're asking me to put an estimate in place for someone who I've never even met. And I get that because the cost for an MRI machine or an ultrasound, it's pretty standard. It's pretty regimented. And an MRI for most of us is a one-time event. Psychotherapy, substance abuse services, managing acute crises, that's not a single event. So they use a wide brush financial secure net to, consumer protection, which I'm in favor of, for a service that's not a single moment in time. And boy, has that disrupted in the worst possible ways us being transparent and available to our constituents. I just can't imagine how they missed that was going to be applied in the wrong ways. And again, I do believe that most medical providers have no idea what I'm talking about, sadly. And most behavioral professionals, whether we're doing it or not, know exactly what I'm talking about. And that's the sad story here. It wasn't even for us.
Yeah.
So again, laws and unintended consequences. Troy.
I'm going on the same tirade with the good faith estimates. We actually did we have an offshore team, and the offshore team produces estimates for us based on the patient's insurance, and we get their co-pays. And the way we've looked at it, like Josh said, it keeps changing. So I'm not even sure what we're supposed to be doing. Nobody knows. But the way we dealt with it is we display every code in the estimate, and we show every possible outcome. And then we have to have a patient navigator talk to the patient to explain it because it's too confusing to understand. And, and then they say, well, how much is it going to cost? And you can't tell them because you don't know. So, in this scenario, it would cost this, and in this scenario, it would cost that. And then, and sometimes they leave right at that point because it just sounds like a really expensive deal. And
Or
it
a
might
pyramid,
not be.
or a pyramid scheme. It sounds fishy. It just sounds weird for us to be telling you in advance, here's what we're going to be charging you. Now, if I'm a consumer, I've benefited from it. Like, I don't want to know that right now. I want
Yeah.
you just to help me right now. And it's a backwards way of scaring people by protecting them. And it's not actually protecting the people in need at all.
Oh, and by the way, you need to sign it. So now
Yeah.
it's like a contract. If you didn't scare them with the first part, right? Yeah.
Yeah.
It's a problem.
Well, so again, that feeds into the significant barriers to care. That becomes another one of the barriers that makes shortages worse, makes access worse, makes the quality outcome worse for that individual patient. So in 2023, one of the focuses seems like it needs to be, as a group, how do we make that right? What are we going to do? What's going to happen in 23 to right that ship and not continue to negatively impact our behavioral health world? Well, we're getting close to the end of our hour, so I'm going to kind of open it up with a question that says, and ask each of you to kind of comment, if you would, in our industry, what do you think we should be paying particularly close attention to in 23? What are you going to be paying close attention to in 23? So I'm going to start with David.
I'm going to be paying very close attention to Jerry Psych. It's an interesting life cycle stage where currently a lot of the providers are going out to ALFs or SNFs or inpatient hospitals and providing the services over there. But with this movement of aging at home, that's soon to change. And so right now, which in industry that's, God, I mean, there's like one geriatric psychiatrist to every 4,500 people seeking that service, one provider for every 30,000 in total in aggregate seeking those services. Something's got to change there. So I'm going to be paying quite a bit of attention to Jerry Psych in particular. I think as an industry, it's a lot of the stuff that we're already talking about, access to care initiatives and health equity, which didn't really get there, but I think health equity is also going to be a big part of value-based care and how we're even seeing reimbursements changing, even if we're not engaged in value-based care contracts. Yeah, I'd say just that those barriers to access, especially as it relates to health equity.
Okay, so focus on geriatric care, and I would say probably too on the other end of that is the same numerics probably apply to adolescent and child psychiatry as well. But with the burgeoning population, certainly of seniors, the combination of not only mental health care but cognitive assessment care will be something. So, Josh, 2023 for you, what's the industry looking at? What are you looking at most?
Well, first, I want to honor and appreciate that David said that. I think just as a field in healthcare, medical and behavioral health, we're terrible at addressing the needs of people who are aging, and not even just the cognitive decline and dementia stuff. I just mean just general healthcare and just in general. And if we get better at healthcare in general, we're going to have longer lives and people functioning at higher levels for longer. I think that's just an explosive area for the next 20 years of us doing a better job getting accessibility to people in need who are either not as mobile or who traditionally would just pass on it because they think they couldn't get care. So David, really appreciate you acknowledging that's a significant subculture in the field of healthcare that almost always gets neglected. Tom, for me, it's the medicalization of behavioral health. It's a little bit of COVID. I hate to overplay the long COVID thing, but we have seen in this clinic and clinics that I collaborate with around the country, a significant increase in behavioral health patients talking about medical issues. And I do believe some of it relates to COVID and, respiratory issues and headache issues and physical complaints. And I do feel like, and the science supports that, we've had a significant increase in anxiety, depression, suicidality, and medical issues showing up in behavioral health care in the last 2 years, a significant increase. But you're having many more behavioral health people being able to talk about and address helping people deal with chronic pain, missed work opportunities, physical complaints, ambulation issues, just issues that really impact us in a physical way. And so I don't know how much COVID specifically is directly linked to that, but as an anxiety specialist, we deal with breathing issues, respiratory issues, oxygen levels, headaches, migraines, curious physical things that people are scared of, which we call hypochondriasis or health anxiety. So in 23, I think really focusing on a more holistic view of our behavioral health patients and addressing, without medicalizing them, because I'm not a medical provider or prescriber, being able to talk about and advocate for their medical needs and medical health needs in the context of behavioral health care, and whether it's addressing it and working on things like chronic pain management or helping them navigate medical services more effectively and not being afraid of them. That's to me a big area in our field of behavioral health as we advocate for our patients' needs in a variety of ways, helping them do a better job addressing their own literal physical health needs. And I just have seen a significant increase in that in the last year or two. And I'd be shocked if COVID wasn't a small or a large part of that discussion with our patients.
Great. Thank you, Josh. Troy.
I'm going to be watching the end of the public health emergency and how that impacts everything we do in telehealth, and in a lot of things we do that it wasn't even telehealth, that it wasn't all telehealth. So I mean, it allowed for non-HIPAA compliant systems to be used. We got telephone encounters, and now I think they're going to try to get away from that. The prescribing things we talked about. And ultimately, I think we're going to find a whole bunch of providers in trouble who were using FaceTime and Skype and non-HIPAA compliant methods of doing telehealth. And they're either going to scramble to fix that, or they're going to be non-compliant. And we'll start to hear about that.
Okay. Well, we're right near the end of our time. And so I guess the next question for each of you would be, do you have any last minute comments, things that you think are important that we haven't touched on, things that you'd like to be sort of that thing you'd like to leave with our audience in your particular area of looking at 2023? And if not, then I'll close it with some comments. But any of you have any last minute things that you think are important to impart to our audience?
I think, and I'm reiterating an earlier point, but I really think we need to get reimbursement down in order to up. I'm sorry, I said that wrong. I think we need to get reimbursement fixed so we can do all these things we're talking about. Everything that we're talking about requires some amount of work, and I think it's great, and I think we're going to do it. But we need to figure out how we're going to get paid for it, because we can't just all do it for free. And so I think that's an important thing I'd like to leave people thinking about. How are we going to do this? How are we going to get paid for increasing our services and making these changes? Okay,
reimbursement.
I'll put out there that this is in contrast, Troy, to what you just shared, which is, as a consumer, don't make, and this is so hard to say, don't make cost how you make your decisions about healthcare, especially in behavioral health. I have conversations on a daily basis with people that I'll probably never meet and our clinic will never meet about getting them to, I think, is the right place. And for whatever reason, they're not either suitable for us, or they're not going to come in, or we don't have the right specialists. But there are outstanding specialists around the country. I'm not talking about generic therapists, specialists in speech therapy, occupational therapy, physical therapy. I'm a behavioral health specialist. I'm a clinical psychologist, that are prideful in what they do. They're highly credentialed. They're highly trained. They're passionate. They're not fatigued. They're not burnt out, and they want to help. And unfortunately, I do believe that co-pays and managed care dictate that people get access to all sorts of kinds of therapists that lack the quality control, the training, and the science to get good care. And I understand paying $20 to $30 a copay for a year is really interesting, and it's less money than what you're going to spend on someone like me, but you'll be in therapy forever or not get better. And I hate saying that, but seeing a specialist in my field, whether it's an addiction, eating disordered, someone who is engaging in superficial or real cutting behavior, in my work, anxiety and mood disorders, Specialists are good at getting someone to a place of symptom management effectively and efficiently so people can really take control of their own lives. And as I like to say, we'll keep having our sessions. You just don't have to keep coming back in, and I'm not going to charge anymore. And I love that. I love turnover in my practice, not because people walk away, Tom, but because they actually get better. And I know sometimes insurance and low-cost services dictates that, and I get that. But boy, do I wish you could find a way to address what Troy just said, so people had access to really amazing therapists who take so much pride in their work and get people to a high-functioning level of life. You know, it's tough to meet people when they're struggling at the beginning, and I love seeing them when they walk out the door. Truly, it's why I do what I do, or I'd be the most depressed therapist in the world. I love it, but not everyone is a specialist or has all the credentials to do what they do. So as a consumer of services out there, do your homework and find a specialist who knows your issues. They're out there.
I'll end with kind of complementing what Troy and Josh just said as well. So, and this is more directed at shareholders of private behavioral healthcare companies. Don't be fooled by your margin, right? Like that saving on or not investing in the company will actually produce a higher valuation for you in an upcoming capital event, whether that's a sale, recapitalization, growth equity, whatever it is. Don't be fooled by that. Saving on margin, right? Like getting EBITDA and your earnings up higher at the cost of not investing in the company itself will reduce in a lower multiple. And that multiple is going to have a much bigger effect than the $100,000 that you end up saving. So invest in those things. Invest in, not trying to do a marketing event for Proem, but invest in things like intake software. Invest in compliance and regulatory software, invest in your staff, invest in all of that. You're going to get a higher multiple on your earnings if you do that. And at the end of the day, it's going to be a bigger number, the bigger top line number that you're going to see if you do that.
Well, I want to thank all three of you. It's a pleasure to hear your thoughts, your ideas, and from all the different perspectives that you have. Certainly, Proem will make this available to others. If there are questions that came in that we didn't touch on or didn't get a chance to answer, we'll ask our administrators of this webinar to provide those for us, and we'll see what we can do to get with you. But again, I want to thank all of you. I think we've offered up some really interesting and important food for thought for all of you that have joined us on this webinar, and would wish all of you a good remainder of your afternoon, and hopefully we'll all talk again soon. So if Proem can be of assistance, certainly reach out to me directly if you have clinical issues or any issues around Proem. We'll be happy to answer those questions. Here's our group. And we'll provide you with that follow-up information, but you can certainly look to us at Proem to provide you whatever answers. Again, thank you all, and to everyone on here, have a lovely afternoon.